Hello, welcome to your online lecture for the course Pathophysiology 2. Today's lecture is Respiratory Disorders 2, so this is the second and final lecture for respiratory disorders. Here's a list of the different topics that we'll be covering in today's lecture. And we'll start with respiratory distress syndrome of the newborn. You'll sometimes see this called surfactant deficiency syndrome. It can be seen in preemies, and it's a significant cause of both mortality and morbidity. Respiratory distress syndrome of the newborn happens, as already mentioned, because of lack of surfactant. Surfactant is a chemical released by type 2 alveolar cells that coats the alveolar wall. Surfactant helps reduce surface tension of a fluid. So the surface tension is created by the force of attraction between water molecules that are found outside of the alveoli. So if it weren't for surfactant, then the surface tension would act like almost like a weak magnet, and the alveoli would collapse. Surfactant helps prevent the alveoli from sticking together as well as air moves in and out of the lungs during respiration. So to summarize that, the presence of surfactant disrupts the attractive forces of the water molecules, reducing surface tension and thereby preventing collapse. I should mention as well that all alveoli, even of different sizes, have the same pressure, even though it would seem to make more sense that the smaller one would have more pressure because of less volume. However, this is not the case. The reason for this is because smaller alveoli have more surfactant to account for their greater surface tension than do larger alveoli. This equalizes their pressure. This, you might remember from anatomy, is called the Young-Laplace law. When alveoli collapse, which will oftentimes be seen in these cases at the end of each exhalation, this decreases the alveolar surface area that is made available for gas exchange. Now, surfactant is synthesized towards the end of the pregnancy. So fetuses will begin to produce surfactant between weeks 24 and 28. By about 35 weeks, most babies have enough naturally produced surfactant to keep the alveoli from collapsing. Here is an image of premature lungs. So this would be from a child that did not survive. And there's evidence of atelectasis. Remember, atelectasis is collapse of lung tissue, and some of it has taken on this completely odd look where it almost looks like the color of the liver, and air cannot get into these areas. So this slide shows you the pathophysiology of what happens with a premature birth and respiratory distress syndrome or surfactant deficiency. But with a premature birth, whether there's surfactant deficiency, which affects the surface tension, whether there's immature lungs or an overly compliant chest wall, in any of these cases, atelectasis can occur, collapse of lung tissue. So if we start over here on the left of the screen in front of you, atelectasis can lead to inadequate alveolar ventilation, and we know that. But what happens in this situation oftentimes is a ventilator is needed to provide oxygen. But the problem with using a ventilator is that it can actually damage the alveolar epithelium, and that can lead to respiratory failure. But what it can also do is lead to a change in permeability where proteins leak into the alveolar spaces. This can end up leading to inactivation of surfactant that was there originally, which can further lead to atelectasis. In addition, inadequate alveolar ventilation can cause hypoxemia and hypercapnia. This can lead to acidosis. It can also lead to impaired cellular metabolism because we don't have the oxygen available for proper cell metabolism, which can lead to decreased production of surfactant, therefore leading again to atelectasis. Atelectasis can also lead to increased pulmonary vascular resistance, which we've spoken about already. Then the lung tissues are not perfused as they should be with the oxygen that they need, which can lead to what's called hypoxic vasoconstriction. Hypoxic pulmonary vasoconstriction is this physiological phenomenon in which small pulmonary arteries made of smooth muscle constrict in the presence of alveolar hypoxia. So I can restate that and say that this hypoxic pulmonary vasoconstriction is really a reflex contraction of vascular smooth muscle within the pulmonary circulation in response to low regional partial pressure of oxygen. Now, this increased pulmonary vascular resistance can end up causing a partial return of blood into fetal circulation with this right to left shunting of blood through the existing foramen ovale and ductus arteriosus. And this can lead to acidosis. So inadequate perfusion of tissue and the hypoxemia that exists contribute to metabolic acidosis. And then, of course, this can also lead to respiratory failure. So you can see that with a premature birth, lots can go wrong and it could lead to respiratory failure in these individuals. Now we'll talk about pneumonia. Pneumonia is inflammation of the lungs. It's frequently acute inflammation. Inflammation really within the alveoli and the alveolar walls. The alveoli are filled with neutrophils and probably macrophages and bacteria, and then the alveoli end up becoming useless for ventilation. Parts of the lung can then collapse because of this, rendering them useless in terms of what their normal physiological response is. And so you can see here how that would look. There are various causes of pneumonia, it's not a single disease. There can be over 30 different causes, but we have listed here the 5 most common causes. Although chemicals can cause pneumonia, so for example, if somebody survives fire exposure, they can end up inhaling chemicals, so inhaled into the lungs that can lead to pneumonia, but infectious causes are the most common. We have here strep pneumonia, etc., a whole bunch of different ones. Staph aureus, which can happen, for example, after somebody has been intubated because we have this bacteria present on our skin, so it can end up getting into the lungs. There's viruses such as the flu and the measles. This is more commonly going to impact somebody who is immunocompromised. Mycoplasma pneumonia, also something that can impact people more likely if they're immunocompromised. We have pneumocystitis. This is potentially what would cause pneumonia more likely in somebody that has AIDS. Chlamydia as a cause, this is rare, but what I would like to point out is that mycoplasma, pneumocystitis, and chlamydia are opportunistic pneumonia. This is showing you an example of location of pneumonia. So this would be the right middle lobe. Part of the lung is filled with inflammatory cells. It can be referred to as lobar pneumonia because it's affecting the entire lobe. So the lobe then is completely compromised and affected, but this does tend to respond well to antibiotics. So if somebody is exposed to Streptococcus pneumonia, it's inhaled into their lungs. The bacteria will adhere to alveolar macrophages, which elicits an inflammatory response. What can happen next is referred to as red hepatization. What hepatization is when there's conversion of a substance into something that resembles the liver. Red hepatization is when there are red blood cells and neutrophils in particular within the pulmonary alveolus, and this precedes gray hepatization where the red blood cells have been broken down. And fibrin will also be deposited, so inflammation can also generate the formation of fibrin in the area. And the hepatization is, as mentioned, where the lungs start to look like the liver. They look very consolidated. There's no ventilation into that area because it's just so full of inflammation. And then eventually there is resolution of the infection. 3 complications of pneumonia are listed on this slide: pleural effusion, lung abscess, and empyema. Remember that pleural effusion is fluid in the pleural cavity, so in between the parietal and the visceral pleura. And down here, empyema is referring to pus formation. And in this upper right image, this is an example of a lung abscess where tissue is destroyed and a cavity forms. It's called an abscess. Oftentimes it has to be drained or removed surgically. Now we'll talk about tuberculosis, which is actually a type of pneumonia called Mycobacterium tuberculosis. Mycobacterium is a rod-shaped bacteria, as you can see nice and clear in this image. It goes into the lungs, it induces inflammation. Macrophages and neutrophils will be brought in and they will phagocytose the bacteria, but the trouble is that they can't digest it in a way that you might expect it to be able to. In the right upper image, macrophages get kind of stuck with the bacteria within its cytoplasm and then they call for help. And other macrophages come together and they differentiate into this epithelioid cell. T cells, you can see, are also present, but at the end it can form what's referred to as a granuloma, which eventually will wall off the bacteria. The bottom image here is showing you an acid-fast stain, so it makes them look purple. And this can still be seen inside the macrophages because they're unable to digest it. This is reviewing some of the steps that I've already mentioned, but the mycobacterium arrives at the macrophages within the lungs, where the macrophages will phagocytose it and become an infected alveolar macrophagy. And it can eventually form this epithelioid cell, as mentioned on the previous slide, and becoming what are referred to as foamy macrophages. And eventually they can start to wall it off, forming this granuloma, and it's a fibrous cuff that surrounds it. Really a method of trying to protect the body, since it can't actually kill the bacteria. But in certain circumstances, it can be freed and then can be passed on to other people because it is very contagious. Sometimes there's also necrosis seen in the center, and it's important to know that this type of necrosis is called caseous necrosis. You can see the spelling of the word here, central caseous necrosis, but it's not necessarily, this caseous necrosis isn't the black color that you might expect with the term necrosis, but rather it gets its name because it takes on a very cheesy and white appearance. On this slide, you can see an example of the tuberculosis. It almost looks like a tumor, but of course it's not. The bacteria can also escape and end up in the lymph nodes, so you can see its presence here in the lymph nodes. On the right, necrosis can actually destroy the tissue and end up forming cavities that are called caverns. So parts of the lungs that have these really big empty spaces that should actually normally be filled with lung tissue. There are two clinical phases of tuberculosis, primary and secondary. Primary is what many people have. So if they're in contact with somebody with tuberculosis, then they can develop primary tuberculosis. What happens is it gets into the lungs, a cell-mediated hypersensitivity response occurs, and a granuloma will form called a Ghon complex. And it's the Ghon complex that is a lesion that can be seen in a person's lungs on x-ray. Sometimes it's an insignificant finding. When someone's chest is x-rayed for whatever reason, there can be evidence of primary tuberculosis. And what it consists of is a calcified focus of the infection. And there would be associated lymph node or an associated lymph node as well. So it really becomes dormant, and these individuals will have no clinical symptoms. And because of no clinical symptoms, unless it was found incidentally on an x-ray, you wouldn't necessarily know that you have it unless you've had a tuberculin test done. And this will really determine, does that person have cell-mediated hypersensitivity response to the bacteria? Now, let's say this person is immunocompromised for whatever reason, then a secondary tuberculosis can occur. And a progressive or disseminated or reactivated tuberculosis is seen in these cases where there's full-blown pneumonia and these individuals are very contagious. So the secondary pneumonia is really a clinical disease. This slide just shows you the incidence rates, that there is a link to socioeconomical there's socioeconomical causes that can be considered, such as poverty, many people living together in a small area, immunodeficiencies, malnourishment, things that you'd more likely see in developing areas of the world. So very relevant for any of you that plan on working in developing countries. Next, we'll talk about pulmonary thromboembolism. We've spoken already about this, but we'll review a few concepts. This is really when a thromboemboli blocks circulation in the lungs. So the question I want to ask you is, do you think this is a thrombus or is it an embolus? Well, it's an embolus or a traveling thrombus, if you think back to the definition of each from earlier in the semester. It comes from the venous system. So for example, a DVT or a deep vein thrombosis, you might have an individual that has varicose veins. They're more likely to develop a deep vein thrombosis, although there are other risk factors as well. But the thrombus could form in the lower extremities. It could dislodge, it could travel upwards through the venous system where it enters through the inferior vena cava, then it enters into the right atrium, then into the right ventricle, then through the pulmonary artery, and it can travel then to one of the lungs, causing a pulmonary thromboembolism. So it really it travels through the heart and then gets stuck in the lungs. So we've spoken about really the top part here already, that some sort of issue with the venous system or issue with coagulation could lead to the formation of a clot. This clot could then be dislodged, or a portion of it could be dislodged, and then it ends up causing occlusion of part of the pulmonary circulation. And that's important to say that it could be just part of the pulmonary circulation, because it usually only blocks one area of the lung. If it's massive, then that's a little bit different. And then some of the events that can be seen at this point is hypoxic vasoconstriction. Remember, I spoke specifically about this term earlier in this lecture, which refers to that reflex contraction of the vascular smooth muscle in response to the low partial pressure of oxygen in that area, and then reduced surfactant production or inactivation, release of neurohumoral and inflammatory substances. It can lead to pulmonary edema and atelectasis, or collapse of the lung tissue. And then some of the events occurring after that can be rapid breathing, shortness of breath. The changes in perfusion can affect remember the ventilation perfusion ratio that we've spoken about in the first respiratory lectures. So VQ imbalance, as well as increased dead space because of the portion that is blocked. Of course, decreased partial pressure of oxygen is referring to hypoxemia. Can lead to pulmonary infarction in certain cases, hypertension because of the blockage. And then what I also wanted to mention is that blood can't make its way back through the lungs to the left side of the heart. And so what will end up happening is it backs up. It backs up because of the blockage into the right side of the heart. And so the left heart ends up not getting the preload that it needs because it can't move through the lungs to actually get back to the heart. And then the right side of the heart has this increased afterload, again, because of the blockage. So if you're having trouble with the concepts of preload and afterload, I do suggest that you try to review it and try to learn it and ask any questions that you have, because understanding those concepts will really help with application to conditions such as this. And then it could lead to, overall decreased cardiac output because of the left side of the heart not getting the preload that it needs. And then systemic hypotension and shock can result. Now we'll move on to talking about Acute respiratory distress syndrome, it's an acute syndrome or condition. It is severe and it can cause dramatic damage to the lungs. As you can see at the top of the slide here, there are many different types of acute insults that can cause acute respiratory distress syndrome. And the bottom line is that it ends up causing this inflammatory reaction in both of the lungs at the same time, leading to severe alterations really diffusely throughout the lungs. You can see that there's damage to those type 2 alveolar cells. We have damage to the alveolar capillary membrane, so disrupting permeability. Microthrombi can form in the pulmonary circulation, and release of fibroblast growth factors, which can end up leading to fibrosis of the lungs. And these final effects can happen all at the same time and can happen very quickly within hours. So before you are too frightened at the appearance of this slide, I wanted to mention to you that all you need to be aware of for this course on this slide here, in terms of additional information, is that the acute lung injury, so written at the top here but cut off a little bit, so whatever the acute lung injury, that leads to acute respiratory failure, you can see these two events are very important. Damage to the alveolar cells and damage to the endothelial cells. And what this will do is affect the integrity of the alveolar wall. In the second image here, epithelial cells and endothelial cells are injured, as we just mentioned, and so the wall doesn't work. And what this can lead to is edema. So there's cell injury, there's lack of surfactant, there's going to be fluid buildup. You can see that's written here as airspace flooding. There's inflammation present, and this is happening diffusely throughout both of the lungs, and this can kill somebody very quickly. Now we'll move on to talking about respiratory cancers. We're going to be talking about laryngeal cancer, lung cancer, and mesothelioma. So this is laryngeal cancer, and it's quite common, especially in smokers. It is a squamous carcinoma. And what can happen with this type of cancer, because it's affecting the vocal cords, is it can change a person's voice. So smokers can have their voice change over time. And it could be cancer of the larynx that's actually changing the tone of their voice. But oftentimes it's ignored, and people will just disregard it as being, I have smoker's voice. So it can be diagnosed late because of ignoring this change in voice, but it's tone, but it's very aggressive and it can metastasize very quickly. The problem with surgery is the removal of the larynx, which, as you can probably imagine, would be awful, and survival is not very high. So lung cancer, we've spoken about this, of course, already in Patho 1, but what I wanted to highlight is that you should recall that it's frequently bronchogenic, so bronchial. It's usually squamous cell carcinoma. It can also be adenocarcinoma. Remember, that's referring to the glands, and in some cases can be a small cell carcinoma. In panel D here, you can see that the presence of the lung cancer, and because it's affecting only one area, it may actually not cause respiratory difficulty. And so this is why it can develop over time and be undiagnosed until it's too late or it's quite progressed, and this individual might start coughing up blood, hematemesis. So that's a major sign of lung cancer, is blood that has seeped into the airways and then it's coughed up. Remember the T and M staging, so referring to the presence of the size of the tumor, the nodes that are affected, and whether metastasis exists. So T1 is referring to a small tumor, so classified here as stage 1. Stage 3, jumping ahead, would be, and you can see the tumor localized here. Jumping to stage 3, it's much larger, so here we have T2 for classification based on its size, but now we have N2 because it has spread to mediastinal lymph nodes, so spread to the mediastinum. And then remember that stage 4 would be metastasis. So this is where we would have M1 or M2. So it's metastasized then to distant organs. Usually it's diagnosed in around stage 3 or 4, which decreases survival. And I know that because that's what happened to my grandmother. She was a smoker for many years, probably 20, maybe 30 years, and then quit for 20 and still ended up with lung cancer, diagnosed too late, unfortunately. So mesothelioma is a specific type of lung cancer. It's cancer of mesothelial cells, and it is malignant despite what you might think of based on the suffix here in this term. And this is cancer that forms from cells that form the pleural membrane. So they form in the pleural cavity and they compress the lungs. And so looking at this image is probably very helpful because you remember your pleural cavity is here, so it grows in here and then it ends up compressing the lung. The most important cause is exposure to asbestos, mainly from being in, working in, or living in old buildings. Since the 80s, most asbestos has been removed and is generally not used anymore, but when it was used for insulation. Pneumoconiosis, this is really a disease of modern life. It's a disease of the lungs due to inhalation of dust, characterized by inflammation, coughing, and fibrosis. Foreign particles that enter into the lungs because of air pollution, for example. So if pollutants and contaminants get into the lungs and they end up staying there. Pneumoconiosis was first really defined in mine workers because of coal exposure. So when it's inhaled into the airway, you get type 2 cells and alveolar macrophages that end up being exposed to and capture the coal, and it causes inflammation leading to pneumoconiosis. It can cause focal dust emphysema. So this is in the case of coal exposure. And nowadays, the use of filters and masks can help prevent this or at least reduce the incidence. But as you can imagine, this is going to cause loss of pulmonary function, generally a slow loss of pulmonary function. Another feature here that's present is you can see that the bronchioles become dilated over time with this condition. Other agents can cause pneumoconiosis as well, such as silica, which, for example, can be exposed to people that are working in mines, breaking rocks down. It's present in many different substances in soil, sand, rock, granite, and many other materials. So if you're cutting and chipping and grinding and drilling away at these materials, it creates a lot of dust, which contains these small silica particles that can be breathed in without even noticing and end up becoming a major health hazard for the exposed workers. And so we can form what's called a silicotic nodule. And with asbestos, which we've already spoken about, it ends up causing asbestosis in these affected individuals and formation of development of fibrosis, and it can lead to, as already mentioned, mesothelioma. And it's not just found in miners, just to be aware, but that was just an example. This image here shows you what's called anthracosis, which the origination of the term means coal, and its osis is condition. And this is a condition caused by the accumulation within the lungs, so repeated exposure to this pollution or repeated inhalation ends up making the lungs have this very blackish, dark appearance. Even when they're cut, you can see that it's still present. So the black particles from really dirty air in the lungs. And this can actually happen in those who've lived in cities all of their life where they're constantly being exposed to pollutants. And you get this black staining that can lead to fibrosis. That is the end of today's lecture. I hope you have a great day.